Dr. Duke Majin, by the way. I'm right behind you. So we're going on the right side.
Testing, can you
Everybody's
hear
in
us?
agreement. The first thing I'm going to do is give you some numbing medicine, okay? So you feel a little stick and burn. That's my hand feeling around a little bit, okay? You're going to get a little stick and burn. That's normal. Don't freak out. Now, if you're feeling pain during the surgery, just say ouch.
Oh,
If you
testing
say
one, two.
ouch to me, then I know you're uncomfortable. And I don't want you moving. I just want you saying ouch, okay? Deal? And I will take care of it, okay? Just give me the ouch if you're having pain, but try not to move around. All right. Okay, blood pressure is looking good.
Testing.
All right, that's just my hand feeling around. Remember, you say ouch if you're uncomfortable.
Testing. Yep, it's working.
Too loud. Shot. Let's go lateral. We're looking a little high. Num num. Skin. Num num. I may want to move a little bit lower. Shot. I can't see. Okie dokie. Alright, well, now we got to sort that out. Can we do that? What we're dealing with here is a lateral view, and you can see that there's a ring. It looks like a metal ring. And that metal ring is actually in her SI joint. You had an SI joint fusion, right? All right. Huh? Shot? Yes, thank you. It's amazing how much movement. Let's see. We want to get right about where the ring is. Okay, I need that disc space lined up. It's not terrible, Jordan, but let's try to wag it and see if we can't get the end plate lined up a little bit better. Huh? Says some more num num. Just giving you some more numbing medicine, okay? Needle is down, watch it. All right, so I need you to move the fluoro south, I guess, Jordan, right? So can you do that without me asking? All right, let's try to get the end plate of 5 lined up better. The end plate of 5. Do you see it? Let's try to wag that in. Maybe the other way, I don't know. Let's take a look at the MRI again real quick. All right, so I see a curvature to the sacrum, and then it stops at 5-1 and goes the other way. So that would be that curve and that curve there. I think that's a little bit better. Let's see if we can't make it better. A little bit more wag. You're almost there. Gosh, that's looking pretty good. I like it. Let's try that at 5-1. What do you think? I think it looks good, huh? All right. We're just doing the positioning part right now. So let me know how you're feeling, if you're feeling uncomfortable, okay? Shot. All right, so we need to go a little bit further south. Shot. 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 Just lay still. Please don't lift your head up. All right, is your neck bothering you? Shot. Can we do anything to help her with her neck a little bit more? Shot. Shot. All right. Now, what is it? Shot. Just lay still. You're doing good. Shot. Shot. We're just trying to get her neck a little bit more comfortable. Shot. 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 We're lining up good. There's a lot of scar tissue here from her facet joint. Shot. Shot. Give me an AP. Go back to a lateral. Let me know if you feel anything at all. Shot. It just seems. Can we wag that end plate a little bit better? Give me the wag control. Shot. That looks worse, huh? Shot. That looks better. Shot. Really hard to tell. Shot. 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 What do you think, Luis? Shot. Shot. You think right there? Shot. Let's see if we go a little more extreme. What do you think about that? That one looks pretty good, huh? Lock it down. You're gonna need to move north a little bit. Just a little bit north. Let's see what that does. Shot. It may change our angle. Release the wag. Shot. I think that's the best one yet, right? Lock it down. Well, I'm not happy with where we are. Let's see if we can make this a little bit better. Shot. 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 I'm definitely getting to the facets. Our trajectory looks good on the lateral view. Shot. 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 Let's go AP. Okay. A lot of arthritis. You can see the bone spurs off the facets. All right, let's try back to a lateral. So far, good. I can see where we are and where we need to be. Is that uncomfortable? Sore? Shot. 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 Why is it just doesn't look right? Do we change the position here? Something isn't right. Maybe she moved a little bit. Shot. Yeah. Jordan, you need to get that fluoro positioned properly. I don't think you're too far off. It's a little better. Shot. 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 AP. So we're just getting caught up in all the bone spurs and arthritis. Anything we can do to make her neck more comfortable? You raised what up? Huh? She need. You need the pillow lower? Okay. So you've been having these problems over and over again. What do you think the problem is? Nope. The neck is extending. That's why they're uncomfortable.
Correct, but if we use just a flat pillow for the neck, it's more comfortable for the patients.
Louise, the problem is you don't have gel pads probably big enough under her body to raise the body so her head can sag down more. Right?
Yeah, that's an option, of course.
I mean, that's probably what we were doing before. I've never heard so many complaints about neck before. Why are we changing things?
We usually use 4 pillows, one on the feet, 2 on the ears, and 1 on the head.
No, that's not what it is. Shot. Lateral. The real problem is you weren't paying attention when Carl was here setting it up properly.
Yes, sir.
And if you had paid attention, you'd probably realize that he was using gel rolls for people to lay on. And then you've changed what we were doing, and now we're creating a problem.
Correct.
Why do you think surgeons do it the same way every single time? We do it the same way because once we take years to figure out what we have to do right, and then we set it, and then people come along and change it. Table down. But it's not acceptable, Luis. It's already hard enough. To do what I have to do with the patient uncomfortable, it makes it worse. You got to learn the proper way. Figure it out.
Is that enough?
Yeah, that's fine. You are so far south on your fluoro, Jordan. Come on. What do you, honestly, you're going through the hips. What's she saying?
We put in the foam donut.
What is she laying on currently? No, what is her body on currently? What is her body laying on currently? Sean? I'm sorry? Just pillows. How many pillows are under her chest? Okay. So, why do people complain about neck pain? Nope. Do they complain about neck pain because their head is too far forward or because their head is too far back? Sure, why not? Let's just keep monkeying around. Shot. Shot. All right. Sorry this is taking so long, but you've got a lot of arthritis down here at the L5S1 area, and that's blocking us from getting in. And I'm just trying to find a way around it, so that's what I've been doing. And you've got a high iliac crest, so it's keeping me from being able to access. Plus, I know you're uncomfortable, so I'm trying to get you more comfortable with my team. Come me lower that volume, please, so I don't have to hear that. Let's move the fluoro north, Jordan. More north. That's too far north, Jordan. That's better. Just keep it there. That's really a good picture. Where are you feeling that? In your back? Shot. AP. Do not lose the lateral. Yeah, she's already moved. Wow. Yeah. Incredible. All right. Try a little bit more medial. Shot. Shot. Nope. Shot. Let's go lateral. See a little bit better on the lateral. All right. Shot. Yeah, just not getting past the bone. Jordan, does that look right to you? I think the other way. That's pretty good. That's pretty good. Now we just need to get further south. And that's where we're having trouble. Shot is getting further south. Not able to. Numbing medicine. Take that. Shot. Okay. Shot. Having to start really high because of her iliac crest and the facet being so big and wide and lateral. Shot. And keep hitting that. Sean? Sean? I don't understand how it's moving. She's not moving, is she? Huh? Sean? There, it's better. Where do you feel that? Through your leg? How far down? To your foot. Is it better? You don't feel that anymore? Huh? Couldn't. You got to tell me what she's saying.
Say it again. Just having a tremor.
That's fine. The tremors aren't a problem, but the pain down your leg is a problem. Shot? All right. AP? You're not having leg pain now, or are you? No? Are you a little bit more comfortable? Yeah, about as much as you can be for being on an operating table awake, right? All right, that's looking good. You can see all the arthritis there, that grayish stuff. Back to a lateral. Well, we're as close as we've been. Hopefully we're close enough. We'll know in a few minutes. This is the bottom disc. This is the hardest one to get. And you've got a lot of stuff going on that make it even harder for me, okay? No, it's okay. It's not your fault. I don't blame you. I just have to make sure we can do it safely. Shot? Any discomfort down your leg? Shot? Well, it sure looks like we're there, huh? Nothing down your leg, right? Any pain in the back? Huh? Where you typically get pain? All right. Now, I can tell you, that's a good shot there with the fluoro. But not down your leg. Shot. Give me an AP. Oh, we're right there. Let's just see where we are on the AP. It's buried to the hilt. That looks good. Well, AP and lateral look really good. Lateral. Now that we've gotten past the facet complex, now we have the basically some osteophyte at the back of the disc. We're not home free. Shot? I can't see. All right. I think your x-ray is a good picture. By the way, if you ever do these types of procedures, you have to make sure that the x-ray is good. Otherwise, if you don't have a reliable x-ray image, you can't proceed. Shot. Well, we're right there. And you can see we've used all of this. Needle. Shot. No, we won't be able to do a discogram, but I think we should keep it. Are you comfortable? Yeah. All right. What is up with these? Okay. We're going to be able to put you to sleep soon, just not yet, okay? We've got one disc that we're very, very close, and now we're working on the other. The problem is you have a really high iliac crest with lots of arthritis, so it just makes it more challenging. But we'll get there. Jordan, you need to be adjusting things so that we can access the 4-5 now, okay? Whatever it is you need to be adjusting, you got to do it without me telling you. Do you hear me talking to the circulator, Jordan? How's our blood pressure? Good? Looks good. All right, that's getting better. You're almost there, Jordan. Maybe a little bit more wag, and I bring the table up perhaps just a smidgen, like 1/4 inch. Let's see where we are. So Jordan, you got to take control and tell him what you want done. What are you going to do? Are you happy with that? Yeah, that's what I would do. No, it's worse. I think it's worse. That's better. That's definitely better. All right. Well, let's give it a shot. Shot. Definitely want to be lower. Shot. Let's see where we are there. Too high. Man, this is both 4-5 and 5-1 are very challenging because of the iliac crest being so high and her anatomy basically. Shot. 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 We're very close. Shot. 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 So, for those of you watching, this is the first part of the surgery. Shot. This is just what we call gaining access to the disc. Shot. And gaining access to the disc basically means that we're trying to get what's called a surgical corridor, basically from the outside world where we are to inside a patient's body, whatever surgery it is. Shot. The surgeon has to get a path that's safe, and whether you're doing endoscopic or open surgery, it's the same. the concept of getting down to the place you have to operate from the outside world is the same. AP, you have to create a working corridor through other tissues like the skin, the muscles, that is acceptable. Lateral. What I mean by acceptable is that it's safe and it gives you, as a surgeon, the ability to bring the tools that you need to do the job properly and safely. And so that's what we're working on, is the access to the herniated disc that's pinching her nerve, okay? Anything? Huh? Do you feel any pain? Where? In your back, but not down your leg. Shot. All right. Well, I gotta say, you didn't make it easy for me today. No, it's okay. I'm just joking around a little bit, but it really was hard. Huh? You're putting me under pressure right now when I'm trying to operate on your back. All right. Balanced. Was I right? Thank you. She's keeping me like testing my memory, which is good. Okay, I think we're in the right spot. Did you have much back pain, or is it all your leg? Okay. Is that the pain you typically get? How bad is that on a scale of 1 to 10? 8 out of 10. I can't test L5S1. I can only test 4-5. It's 8 out of 10 concordant. But this is the time we get to put her to sleep. When you wake up, we'll be done, okay? All right, we're going to go ahead and put her to sleep. Yeah, just lay still, and when you wake up, we'll be done, okay? You did really good, by the way. Thank you for trying to be helpful. All right. So, folks, this lady, you can see the herniation at 4-5. You can see at the back of the disc, the tear, and you can see that herniation bulging out towards the needle into the foramen. That's what we're after. That is pushing on her nerve, causing her leg symptoms of weakness. That's why we're here today, okay? We're here for the weakness that she's developed. And she has back pain too. We're going to fix that as well because it's caused by the same problem. It's caused by that herniation. Now, the herniation pinching the nerve root is not causing back pain. Can you count from 1 to 100 out loud, please? Nice and loud so we can hear you. Don't stop. Nice and slow. Nice and slow. You're going to feel some burning in your arm. That's just the medicine going in. Propofol? Can you count? Really? That fast? Is she okay? Can I proceed? All right. So the most stimulating part of the surgery is kind of what I'm going to put the guide wire down, and then we're going to take this spinal needle out, shot. And then as I bring the dilator down the guide wire in about 1 minute, it's going to pass through the annular tear where her pain is coming from, shot. And that's what's going to be the most stimulating. And then once I start working with the laser and I get to the outer annulus where the pain fibers are, that's going to be the second most stimulating. Just so you're aware. So it's about to get a little stimulating, but I wouldn't give her any more unless you feel she needs it. Everything's okay. So now we're bringing our dilator down, shot, to the L4-5 disc. You can see it touching the herniation right now, as a matter of fact. And the reason the patient has to be awake is you don't want to hit the nerve root and then you've gone through the nerve root with your needle to get there, and oh, what do you know, shot? Am I okay to proceed? You've gone through the nerve root, and oh shoot, right? Shot. You don't want an oh shoot moment, basically. So to protect the nerve root, patient has to be awake. Shot, and the patient was awake for the key part. She keeps pushing the needle, the guide wire out. Shot. All right. So the guide wire is inside the disc, and it's guiding the dilator. Shot to go into the disc. Shot. Let's try to get her a little bit more relaxed, only because she's tightening up her muscles. So whatever you think is safest for her. Typically, I think it's propofol, a little Versed, maybe. I don't know about fentanyl, but whatever you think is appropriate. I just want her not tightening up her muscles because she's uncomfortable. I don't mind a little bit of movement, Shot. If I just don't want you to have airway issues, you know. So that's the most important thing, is the airway right now. I can tolerate a little bit of movement. This is the most stimulating part, by the way. You know, as we're passing through the annulus where the tear is. Once I get this in, it's less stimulating for the patient. Shot. So, looks like it's in, right? Wouldn't you agree?
I agree.
Yeah. Shot. Yeah, we're in. So our tube that we're doing the surgery through is actually inside the disc space right now. You can see it on the x-ray. If you know your anatomy, you know that we're passing through the foramen to get to the disc space. Okay. And once again, for those of you who haven't seen these surgeries before, or even those of you who have, we're doing the entire surgery through an endoscope. It's done endoscopically. So same kind of endoscope as orthopedic surgeons use to do shoulder or knee surgery. We're doing it on the spine now. And this is a procedure called the Duke laser disc repair. Her alternative would be to have an open surgery, and the problem with the open surgeries is that you have to do a more extensive surgery to treat the leg symptoms that she has. She has leg symptoms from what's called lateral recess or foraminal stenosis. And that's not the same as central stenosis. So a laminectomy by itself won't work. You have to actually take most of the facet joint out if you want to treat it effectively. Laser. So to treat this disease with open surgery, which is what most other surgeons know how to do, they're going to have to remove a fair amount of her bone in her spine. That's going to weaken her spine even more. She's already got some instability from the injuries to the joints in the past. And as a surgeon, you don't want to make somebody's joints more unstable. You want to make them less unstable. That's our goal. But if you start removing bone from the spine, you're going to make their spine more unstable. So it's really important as a surgeon that you kind of weigh your different treatment options carefully for your patient to minimize the procedure and the risk that they have to get better. So this particular patient has herniations in the lateral recess and the neuroforamen that are impinging on the nerve root. So she needs her nerve decompressed. But at the same time, she has back pain. And pinched nerve roots don't cause back pain. They never cause back pain. So the only way people get back pain is from something that causes back pain. Well, one of those things would be a facet joint that has arthritis in it. The facet joint arthritis is the most common cause of back pain. This patient certainly is a good candidate for having that condition. There's lots of arthritis. However, standby laser, we also know she has a herniated disc. And what most doctors and surgeons don't know is that herniated disc can cause back pain. And they do quite often actually. But there's also a lot of times they don't cause back pain. So figuring out whether the herniated disc causes back pain, it takes some special testing or it takes some experience that most doctors don't have. Okay, when I say most, I mean about 99% of them. So if you're having back pain and you're not sure why and your doctor can't fix it for you, you need to go somewhere where they can fix it, like Duke Spine Institute. Okay? So we're not dealing with just a pinched nerve. Unfortunately, the treatment that most surgeons have available, microdiscectomy for this type of problem, requires the bone to be removed from the spine. Now again, that's just going to make things worse. Plus, a microdiscectomy won't treat the back pain. Okay? So you've got to do more than just a microdiscectomy if you want to get rid of the leg symptoms of weakness, numbness, pain, and back pain. Again, because pinched nerves don't cause back pain or neck pain. Pinched nerves cause leg pain, or if it's in the neck, they cause arm pain, but they don't cause back pain. What causes back pain is inflammation, and that's right here is what you're seeing as the source of the back pain. This is the herniated disc, and not really the herniated disc, it's actually a very specific part of the herniated disc. Okay, so if you want to think about it accurately, there's granulation tissue right there. That's where the back pain comes from. It's the granulation tissue found within the annulus fibrosus. Okay, that's what causes it. It's the inflammation within the annulus fibrosus. The annulus tear, and not just all annulus fibrosis, but specifically a torn annulus fibrosis. When you get an annular tear, that's what's called grade 3, 4, or 5, because there's 5 grades of annular tear. Grade 1 and 2 generally don't cause pain, okay? But when you get to a grade 3, which is a through and through, from the inside to the outside of the annulus, a full tear, or grade 4, which is a full tear with a herniation, and then grade 5 is a full tear with an extrusion of the disc material. So when you get to a 3, 4, or 5 annular tear, now you can actually get back pain from that, because the inside of the annulus where all tears start, the inner annulus, the inner half of the annulus doesn't have any innervation or pain fibers. So if you get a tear on the inside of your annulus, the inner half, you don't even know it. You won't feel it. It doesn't hurt, okay? Because it's not innervated and there's no blood vessels there. Everything that gets to the inside of the disc comes from diffusion. There's no blood supply to the inside of the disc. So without a blood supply, you don't have nerve fibers either. But how do you get a blood supply? Well, when you tear your annulus from inside to out, the tear extends to the periphery. Well, that's where the blood vessels are. And guess what, folks? The human body is amazing. It actually can grow blood vessels. So since the blood vessels are in the outer half of the annulus, once that tear goes all the way through, those blood vessels start growing to the inside of the annulus. They grow along the tear where the inflammation is occurring. It's the blood vessels that make the inflammation happen. And the inflammation is in response to one and one thing only. That's what's called the interposed nucleus pulposus. Interposed is the magic word. And that's the part that nobody talks about. Because frankly, surgeons don't even know that that's the cause of the pain. All they think about is pinched nerves or pinched spinal cords. It has nothing to do with a pinched nerve. It has to do with inflammation within the annulus fibrosus. That's the source of the back pain. But because neurosurgeons don't usually deal with pain, they deal with pinched nerves, nerve roots, and pinched spinal cords. They don't care much about all this pain schmain thing. But I learned a long time ago, if you want your patients to be happy, you got to get rid of their pain. So I started to ask questions. Well, why? Why do they have pain, and how can I get rid of it? And I was getting rid of it with my open surgeries, but it was always a fusion. You can't get rid of back pain with a microdiscectomy. And I started questioning why. And of course, like everyone else, I was taught that the spine was unstable. Then I did fusions on some spines that did not have listhesis, and they work. And I realized even if you have facet pain, you can do a fusion and get rid of the pain. You know, for people who failed facet joint injections. So I realized that by stopping the movement of the arthritic joint, you're able to get rid of the pain for patients. That nothing else really works. So I started to realize there's something about the disc that has to do with pain. Not just the facet joints, but the can be a source of pain. There's a lot of pain management docs that understand that. There's chiropractors that understand that the disc is a source of pain in many patients. An injured disc, not just any disc. It has to be an injured disc, not normal discs. Normal discs don't cause pain. Normal discs never cause pain. It's only when you have what they call a sensitized disc, which is basically what I figured out is a disc with inflammation. So an inflamed spinal disc. See the tear right there? You see the tear and a little bit of epidural fat? That's the source of the pain right there. You see those white fibers at 12 o'clock? That's called the posterior longitudinal ligament. So isn't this an elegant surgery, folks? You're watching. There's no blood. There's no bleeding. You know, we basically dilated the muscle to get here, which means we didn't tear it or cut it. We just spread it. So we're not tearing blood vessels or cutting blood vessels like every other spine surgery does. All the other spine surgeons have to cut the muscle and move it, or cut through the blood vessels and you get bleeding. There's no blood here. It's relatively bloodless surgery. And this is the source of the back pain right here. This inflammation, this inflammatory, this all scarred up, call it collagenized, chronic inflamed posterior disc. This is right where the herniation went through the annulus. Do we have any questions from our audience?
We do have one.
Sure.
We have a person asking, can you perform this procedure on the thoracic spine?
Thank you for asking, first of all. I chuckle because we do get that question quite often. The answer is generally no, it cannot be done on the thoracic spine. However, I have done it at the lower thoracic level. So if you have a T10, T11, or a T11, T12 herniation, it can be done. But for the most part, if you're having anything above T10 herniation, the answer is no. Now I have other techniques that can cure pain coming from a herniated disc above T10, and it just involves surgery, a different kind. But it's doable. It's still outpatient. You still get to go home the same day. And so, but it's not with the endoscope and laser. So to answer your question, summarize, thoracic disc herniations can be done, but only when they're T10, 11, T11, T12. The reason is that those levels have free-floating ribs, and they can be moved a little bit, so it makes the access possible. Otherwise, the rib head will, where it articulates with the transverse process, doesn't allow it. All right, so I'm almost done with this disc, and I'm going to talk to my anesthesiologist for just a moment. She's doing really well. I'm very happy. Blood pressure's good. She's not moving around. But I'm going to try to get into the next disc. The next disc is going to be harder. So the reason why is that we're right on the periphery of the disc. We couldn't get in because of the angulation. I couldn't get the needle to go in. So I can still access it, safely as long as she's relaxed. Like if she's tightening her muscles up, she's going to cramp down on the bones and her vertebrae, and that'll put pressure on that disc. And it won't let me in. Basically it'd be like locking the door. So if we can just keep her comfortable, I'm not asking you to change anything. I'm just saying, why am I getting so much bubbles? I understand, but you're pressurizing them? Okay. All right. You can see the epidural fat there. So we got rid of the herniation. It's gone. I'm literally visually inspecting and I see it's not there. And I took out a chunk of herniation earlier with the grabbers. A couple of them actually. So I'm feeling pretty good about this right now. I'm a little concerned about the next level. So these broadcasts, by the way, folks, if you haven't watched before, they are live. We do live broadcasts because we want the public, the viewer, whoever it is that wants to learn, we want you to see the truth. And nobody else in the world will ever show you live surgery like this broadcasted publicly to the whole world. Mostly because if you think I have a hard time in here, most surgeons have a much harder time during their surgeries. So there's a lot of pandemonium and fear, sometimes a lot of cursing that goes on, but they don't want you to see all that, plus mistakes, lots and lots of mistakes during surgery for most surgeons. They'll never admit it to you. Many of them don't even realize it, but they certainly wouldn't broadcast their surgeries live. I think I'm the only one crazy enough to do it, probably in the world right now. So we started broadcasting surgeries live 5 years ago because we really wanted, our mission was to educate the public about the advances in spine care and spine surgery. Educate. There's too much misinformation out there, in my opinion. So one of my goals was to provide the public with the truth about spine care. Not just surgery, but anything, whether it's epidural injections or facet joint injections or insurance benefits or therapy and rehabilitation. What's the best treatment? Do non-steroidal anti-inflammatories work? Are they a good treatment? Blah, blah, blah. There's literally a million laser-off questions that can be asked about the spine and how to cure pain, because the people living in pain every day, they're suffering. And in my opinion, they're suffering needlessly, because there's a cure for 99% of back pain. The only thing we can't cure today is chronic radiculopathy, which is basically if you let your nerve get crushed on for too long, it doesn't get better after surgery. Actually, let me have the laser for just another minute. And fibromyalgia, okay? You can argue myofascial pain syndrome as well, but that can usually be resolved with trigger point injections and therapy. But fibromyalgia, there's no cure, but I'll be honest, in 22 years of treating patients with back and neck pain, I've probably seen 3 fibromyalgia, real fibromyalgias. The problem is all these doctors that they don't know how to treat pain or cure it because they don't know how to treat facet joints. They don't know how to treat a herniated disc properly to get rid of the pain. So when the patient doesn't respond to the initial attempt with anti-inflammatory or steroid or even therapy, the doctor proclaims them as a fibromyalgia patient, somebody who's not curable. Well, actually they are curable. You just need to make the right diagnosis. Now, if the diagnosis is facet joint syndrome, you need a facet joint treatment, which is a rhizotomy or a facet joint injection or a stem cell injection, whatever. But you need to treat the right cause of the pain. The problem is most doctors, when I say most, I mean 90%, cannot treat the pain properly because they don't have the training, they don't have the experience, and they don't have the tools to do it. Okay? So they proclaim the patient back pain as being something that the patient has to live with. It's something that can't be fixed. What they should be doing is saying, you know what, go to Duke Spine Institute. They'll fix you there, okay? Why is that true? Because we literally at Duke Spine are able to fix about 90% of people with chronic pain and get rid of their pain, at least 95% of the pain in 90% of the patients. Okay? However, some people don't have the insurance coverage for it, and, you know, we can't help it if the insurance is the reason you're suffering. We don't control the insurance companies. You do. So we have the technology to fix pain, but unfortunately for some people they're not able to because of the insurance benefit. That doesn't make your pain uncurable. It makes the insurance company the source of your pain. All right, we're done with this disc. Or the cause of your pain. I shouldn't say source. The source is still your back, whatever it is in your back or neck, but the reason you're still having pain would be your insurance company's refusal to pay for your treatment. We get that a lot, by the way. I mean, insurance companies every single year keep sending us their new coverage determinations, okay? Oh, we're not going to cover facet joints anymore. Or we're only going to pay for one facet joint, even though the patient has 2 or 3, which is most of the time. So we have to deal with the insurance companies playing games to try to get out of paying. That's why their profits have risen so much in the last 10 years, because they've been denying more and more treatments that doctors do and have done for years that work. And they just call them experimental because there's nobody to stop them except the patients. Put pressure, please. And the patients don't. They don't stop them. Unfortunately, most of the time they don't. However, if a patient were to stand up and say, you know what, I want this procedure because I want to get out of pain, they could fight and win. And if enough people did it, they would send a very loud message to the insurance companies that they need to do what they were hired to do, which is pay my bills and spread the risk out. It kills me to see patients, let's get an x-ray, that are suffering with problems that are completely fixable because their insurance company just doesn't want to pay the bill. All right. Now I'm going to give it a good effort here at 5-1. The problem is I'm not inside the disc, I'm just outside. And that's because of the high iliac crest and the angulation and the facet joint arthritis. So, shot. Let's shot. Well, I think we have a safe corridor to work in. The question is it going to be good enough? We're going to give it our best effort. Shot. I have to just take a lot of shots here because I want to make sure that we're not moving out of position. Wait. Take that shot. So that's the guide wire right down to the disc through the foramen. The real question is can I position this appropriately without moving it and, you know, risking hurting the patient? That's going to be the big question because we didn't get it docked inside the disc. So shot. And I don't want to cause any problems for her that she didn't come in with, okay? So, hey, how are you? You doing all right? You feeling some discomfort? Can we help her out? All right. We were just talking about you, and everything went well with your first disc. Now we're working on the second one, okay? So I'm just want this to go perfect for you. Sean? Try to lay still and we'll be done in just a few minutes, okay? She doesn't need to be awake from first to second. Typically we keep them asleep, but whatever you're comfortable with. That's fine. Sean? I'm just saying, but we don't need to wake the patient up. So when I first started doing these, we used to wake the patients up. Sean? You're awake, I know. I'm just saying, I'm just talking to our anesthesiologist, Dr. Rudolph. Sean? We used to... Just relax, try not to move. You're doing really good. We're making perfect progress here. Shot. Yep. Shot. Shot. We're making good progress. You're doing really good. Are you awake? All right. That's okay. She's doing fine. Let me know if it's uncomfortable for you. That guide wire is just killing me. You see it? Where do you feel that? Huh? What? No, let me see. What? What'd you say? Take this. Just lay still. Let's get a shot. See where we are. All right. So I need to get a little more south. Shot. Shot. This will be the more stimulating part. Shot. Take it. Take it. This is where I need her to try to be as relaxed as possible. Shot. 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 I don't know how I did that. That was a struggle. Phew, thank you, Dr. Rudolph. All right, let's get a quick AP. So, once again, folks, just so you understand, people with a high iliac crest bone are really challenging to do. That looks perfect. All right, back to a lateral. So what the iliac crest bone is, it's your pretty much your hip, like your hip bone, not your femoral head, but the part where the acetabulum is. It's a big bone that kind of wings up like this right here, where my hand is. It's just like that. So if the iliac crest rises high, everybody has a different height. Then I got to start higher and angle down more. And then when the facet joints have arthritis on them, like hers do, it forces me lateral. So this was on a scale of 1 to 10. This is probably a 9.5. A 10 I probably wouldn't be able to do, but we got lucky. Shot. We're able to do it. Again, you can see the L5S1 disc space is right where her screw is for her SI joint. SI stands for sacroiliac. This patient's had a sacroiliac joint fusion. Unfortunately, they become very popular. Though I think perhaps a little bit overperformed on people who don't need them. We treat SI joint pain all the time at Duke Spine. We do it without fusion. Fusion is very aggressive. We do it with injections, needles, stem cells shot. We always start with a diagnostic block to confirm the SI joint is indeed shot, the cause of the patient's pain. And then after the diagnostic block shot. Yep. Interesting. Shot. All right, I think we're in. We're good. After the diagnostic SI joint injection, we then will do steroid first. It's a great indication for using intra-articular steroid injection with therapy. And there's certain types of therapy you have to do. Shot? Okay? You can't just do any old therapy. You got to have the right therapy done. And that requires a very experienced therapist who knows what they're doing. I don't mean just somebody who's been in the business a long time. I mean quite literally someone who knows what they're doing. So it's always hard to find the right people. Let's take a look. We're a little bit posterior, but I think we're okay. What I mean by posterior, look at the angle, just so you understand, okay, how difficult this is. If you've been a watcher of my broadcast, I'm literally at her head. I have to start at her head to get down to L5S1, the bottom of her spine. Normally, I'm not here. Normally, I'm over here, like right here. I am literally another 1.5 feet north towards her head because of the angulation. Okay? Very, very interesting. But it just highlights, that's herniated disc. It just highlights the fact that her iliac crest is so high and the angle of her disc space is so much angled front, top to bottom. Oh yeah, a piece of herniation there. Uh-huh. Okay. Yeah. 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 Myofascial pain syndrome. First of all, I'm like you. Yeah. Yeah. Myofascial pain is inflammation in the muscles and the tendons, like trigger points, lots and lots of trigger points. And it's treated with, muscle treatment, anti-inflammatories successfully. All right. Typically in the shoulder girdle and can be in the lower back. Again, I'm just telling you, I've seen hundreds of thousands of people with back pain. Hundreds of thousands. I can't even begin to tell you how uncommon it is. I think it's overdiagnosed. In other words, when doctors don't know the cause, wow, my camera is hitting her shoulder. I'm so high up north. That's part of the herniation, by the way, just in case you didn't know. And try to get rid of that. When doctors don't know why people have pain, they just kind of go with what they've been told by the drug, the pill pushers. I'm not going to call it the pharmaceutical industry, stand by, but they've got these little cute drug reps come into their office saying, oh, our drug's been approved for myofascial pain. If you have a patient with pain, you can give them this drug. And, you know, they're giving them oxycodone or something like that. Whoa, look at the size of that herniation. Holy crap. That's what was hitting the nerve, by the way. That's just part of it. So the reason it's inside the disc is because I shoved it in there, right? When I put that dilator in, remember? That's it, though, right there. It's a beast. But you can see how bloodless the surgery is. So myofascial pain is what Dr. Patel treats primarily. It's not a surgical treatment. If it's true myofascial pain, which, again, rare. Damn. But what myofascial pain usually is called myofascial pain is facet joint syndrome, which is completely curable with, you know, facet joint treatment, rhizotomy and therapy. So one of our questions, folks, was, tell me a little bit more about myofascial pain. I'm interested in learning about this condition. Again, it's an overdiagnosed condition. In other words, people are diagnosed with it when they don't really have it. Now, sure, could you argue that their pain is myofascial? Myo means muscle, fascia means fascia. It's the connective tissues around the muscle. So, do they have pain in the muscle? Sure, they have muscle spasms. Is that the primary problem? No. The underlying problem, the cause, is the facet joints, usually, or a disc herniation. So if you get to the cause, the facet joint inflammation or disc herniation inflammation, then you can treat the cause and the myofascial pain miraculously goes away. Oh yeah, there's a chunk of herniation right there. The myofascial pain miraculously goes away. So, same thing with the fibromyalgia. For all the people inappropriately diagnosed with fibromyalgia, their pain will go away too. So, why was fibromyalgia, why was myofascial pain overdiagnosed so much? Well, I've told you already why. It's a combination of ignorance on the part of the doctors and society as a whole, combined with the drive of pharmaceutical companies recognizing that somebody with a chronic pain condition like myofascial pain or fibromyalgia is basically, there's quote unquote no cure, right? So they're going to need to be on pills the rest of their life. Well, hey, here's our pills. Take our pills, you know? So that's kind of where we are. That's after 50 years of basically abusing pain meds, inappropriately using them. But the only reason is really, the truth is that doctors just don't know the causes of pain. They don't know how to fix it, and it takes a specialist to fix it. So who can fix chronic back pain or chronic neck pain? Well, you have to know the cause to know who can fix it. And like I said, probably 80% of chronic back pain and neck pain is due to the facet joints. So your answer is a doctor who treats the facet joints. What kind of doctors treat the facet joints? Well, chiropractors treat the facet joints, and they know how to crack your back and alleviate facet joint arthritis pain. Problem is, the treatment is so painful to do because it stirs up pain while you're treating the patient. So the best treatment is what we do at Duke Spine Institute. You take those inflamed, painful facet joints and you treat them with something called a denervation rhizotomy, where you go in and kill the pain nerve to the joint. That's the first thing you do. And once you've done that, then the joint doesn't hurt anymore. Guess what you do next? You guessed right, you do the therapy. You basically break up all the scar tissue inside those joints with chiropractic manipulation of the joint combined with physiotherapy. That's what we do at Duke Spine, and it works. So the problem is that only about 1% of doctors know this. Why is that? Well, who teaches the doctors? The universities. right? And where are all these drug reps hanging out? The universities. Schmoozing it up, buying steak dinners, giving PowerPoint presentations, misinforming them to believe that there's no fix for the pain, that it has to be done with medication. Patient has to be on medication the rest of their life. Imagine if you had diabetes and there was a cure. What if I could cure your diabetes tomorrow with a procedure, a surgical procedure, and you'll never need those those diabetes medications the rest of your life? Wouldn't that be better for a patient? Especially if it was a minor procedure like an arthroscopic procedure that takes an hour. That's what Duke Spine has done. We've created a procedure that eliminates back pain and neck pain, so you don't have to be on pills. Okay, now, this procedure, this one in particular, the Duke laser disc repair, look at that herniation. See it coming out? Ah, it broke again. Unfortunately, most herniations are fragmented. They're in little pieces. But we're going to get it. And once I get it, we're just need a little bit more and we'll be done. Oh, it wants to come. It wants to come. Oh, I think we got it. Oh, yeah. Bam! What do you think, Doc? Huh? Look at that thing. That's what was hitting the nerve. Can you guys see that?
Yes, we can.
All right. That is probably a really good size herniation fragment. Now, let's see what we got left. There's still a little bit left. We're going to work on it. I'm going to have to bring the tube further back, though. It's always fun to fix these things endoscopically. You can actually see what you're doing. Believe it or not, 99% of spine surgeons, they all do these microdiscectomies to remove these. They've taken the bone out of your spine, but more importantly, they really can't see what they're doing very well. Now, those with a good microscope, like we have here at Duke Spine, is a $200,000 microscope. Very few have it. They can see pretty good. Can't see everything, but they can see pretty darn good. The best way to see is the endoscope. That's what you're looking through right now. We're actually looking inside the disc, right at the herniation. There is no better view in the world than these endoscopic transforaminal views. They're really quite impressive. Now, I wasn't the first person to stick an endoscope in someone's spine. I cannot take credit for that. I don't know who was. If I had to guess, it's either Dr. Parvis Cambin, K-A-M-B-I-N, from the University of Pittsburgh, who was a pioneer in endoscopic lumbar spine surgery, or I would put my money on Dr. Bonatti over in Tampa. One of those guys, I believe, and it could be a woman as well, but those are the only two I know that go back about 30 years, and Dr. Cambin even longer, to do endoscopic spine surgery. Now, the way they did their endoscopic spine surgery is very different than what you're watching right now, the Duke laser disc repair. The endoscopic views were not like they are now. This is a high definition, really high quality because of the equipment that's available. Now, this equipment that I'm using is made in Germany, and it's all FDA approved, of course. Almost. Oh yeah, baby. It's all FDA approved. Everything we do is FDA approved. If you're using non-FDA approved stuff in medicine, you're committing a criminal act, and we don't do that here. Other people do. Right? A lot of crazy people out there that try to make money off of servicing patients' back and neck pain. They do anything to make money. They'll sell their mother down the river. Unfortunately, it's really hard to know who those people are. But at Duke Spine Institute, we don't. We use the highest quality, the best treatments. The thing about it is, as a neurosurgeon and a spine surgeon, I'm able to do any type of spine surgery out there. I've been trained to do it. I'm very good at doing it. The reason we do this surgery is because this really is the very best for patients. It's the least invasive. We need 10 minutes maximum. We'll be done, Dr. Rudolph. 10 minutes maximum. I should be done in 5 probably, but we'll just say 10 minutes. Because this is all scarred up, calcified. You see the calcium right there, that white stuff? This is a calcified disc herniation. When you hear about a disc osteophyte, that's what you're dealing with. It's basically a bone spur, which is a calcium deposit, and we're right at the back of the disc here. And as long as these guys come out nicely, they know they've been beaten. As long as they lose with dignity, right? Then we should be done in 5 minutes. Now, if they want to put up a fight, then it may be 10 minutes. You didn't know neurosurgeons actually have a sense of humor, did you? I'm sure you've worked with a lot of neurosurgeons in your career, haven't you? You, yeah. Where do you work with neurosurgeons? At the university? Where?
St. Joseph's in Tampa, Morton Plant.
Okay. Have you practiced in Florida only your whole career, or have you been? Emory. Yeah, sure. Yeah. I interviewed at Emory for neurosurgery. Hi, we're almost done. You can be. We're right on your nerve. We're not in it. We're just next to it. So it's not surprising that you are. Remember, we're unpinching your nerve going down your leg, right? Yeah. Did it stop or is it still there? Yeah, we are literally finishing up. So you're doing a fantastic job. I'm on the last 2 minutes. You're probably feeling them again, right? That's just the laser, believe it or not. Our patient is completely awake, and she's laying here and doing such a great job. I got about 2 minutes left. Can you bear it? Yeah. Otherwise, we have to put you back to sleep. We're just about done.
Oh, perfect. Thank you.
This is the back corner of the herniation, folks. Right where the nerve is. I think we're pretty much done. Let me see if I can grab out any more. We got some really nice chunks of herniation out, so I think you're going to be very happy when you're all healed up. Yep, everything, and honestly, it went better than I thought it would go.
Lots of work though, huh?
Huh?
Lots of work for you.
I couldn't hear her.
Lots of work.
I think it's going to work well. All right, the nerve is going to be right up here, north. Yeah, you made it very challenging for me, but we still got the job done. The nerve is right there. You all see that white thing? I'm turning the scope. It's at whatever, like 2 o'clock. That white thing. That's the dura around the nerve root. That is her nerve root, and it was getting pinched right here by a herniation. Herniation's gone. Herniation's gone. We're going to wake you up, okay? Even though you're already awake. Don't ask me what kind of saddle. I did a really good job for you, so I shouldn't have to tell you right now. I'm giving my mind a break. Yeah, I think you're gonna be real happy when you're all recovered. So, and the anesthesiologist did a fantastic job. Yeah, sorry, I know that's a bit uncomfortable. Yep, that's all that arthritis down there. You know, we had to navigate around some big, like, mountains of arthritic joint. You okay? Yeah. Awesome. Well, we got both discs fixed. I was very skeptical. I would have given it a 50-50 at L5S1. I almost stopped because I couldn't get the right angle. But everything went really well, much better than I expected once I got in here. You know what I mean? I mean, looking at your MRI, you cannot tell where the iliac crest is going to be. You can't tell how difficult the surgery will be. I mean, there's some things you can look at that will tell you, like the short pedicles and the arthritis and the facet joints. You know you're going to have a little bit of trouble, but those are pretty easy usually. It's really the iliac crest that made it really hard. But we got it done. I'm so happy for you. All right, Luis, pressure.
Yes, sir.
I'll see you in recovery, okay? Nice job. Thanks for being a really good patient. Okay, I'll come answer questions. So start typing your questions, folks, if you have any about the surgery. Thank you. Dr. Larry Duke Majin, and we're just wrapping up a Duke laser disc repair, right approach. No questions apparently from the audience. You know everything. It's good to know. Good to know. Maybe I should talk less. So, let's reflect on a few things about this case. So, first of all, as I said earlier, we're in the middle of a COVID-19 pandemic. There's restrictions on surgeries. We are no exception. We've cut back about 80%, maybe 90% on our surgeries. A lot of our patients don't need the surgery today. As a result, they don't have any nerve damage or nerve compromise or spinal cord compromise. So we've rescheduled those patients, postponed them. But the patients we're operating on today, they all have neurological compromise, pinched nerves. And the longer nerves are pinched, the more damage there is to the nerve. All of our patients have weakness in their legs. This patient was the same. She had 2 herniated discs on the right side, and those herniated discs were pinching the nerves, the nerve roots, I should say, and then those nerve roots go down to the muscles in the leg and the skin in the leg, and she was having weakness in the muscles as a result. So we cannot postpone these types of surgeries. These are urgent surgeries. And in the state of Florida, urgent is many, many things, life-threatening, but also limb-threatening, and neurological surgery and neurosurgery to decompress nerve roots is definitely one of the surgeries you should be doing and not putting off on patients. Otherwise, it's really below the standard of care. So we did her surgery. We had another patient earlier we had to cancel because of blood pressure issues. We couldn't get her blood pressure under control. And then she was wiggling around everywhere because her shoulder was hurting and she had to go pee. So we just had to, move that surgery to another day. Mostly the blood pressure is the reason. Now we've got 2 more cases coming up. Both of these patients for the rest of the day have pinched nerve in their back. The nerve root runs down again into the leg. The next patient is the right side as well. She has right leg weakness with a drop foot developing. So we're going to go in and remove the herniation with the endoscope and laser. So is a Duke laser disc repair surgery a better surgery than open microdiscectomy? Absolutely. Better than laminectomy? For sure. Better than fusion? Better than arthroplasty? Yes. It's better than all those surgeries. I can do all those surgeries very easily. I could do them in my sleep. I've done them hundreds of times on many, many patients without complications with great results. However, the problem is the results from those surgeries are never better than the Duke laser disc repair procedure you just watched. The Duke laser disc repair endoscopic surgery has the best outcome results of all spine surgeries for herniated disc, period. And what I mean by that is what we're treating, remember here, is patient symptom or patient exam finding. We call that a sign. Patient signs and patient symptoms. So what exactly, from a patient sign standpoint, are we treating when we treat a herniated disc? Number 1, back pain, or if it's in the neck, neck pain. Number 2, pain down the leg, or if it's in the neck, pain down the arm. Number 3, weakness in the leg, whether it's a dragging your foot, drop foot, leg weakness, or if it's in the neck, a weak arm or a weak hand. Next, clumsiness of the leg. That's usually due to the weakness and loss of sensation. Sensory deficits in the leg, such as numbness in your foot. So all of these symptoms of back pain and leg symptoms, including pain down the leg, numbness, tingling, and weakness, those are patient symptoms. Now, sometimes patients have no complaints. They'll say, oh, my leg isn't weak. And then I go and examine them, and what do you know? Their leg is weak. They can't cock their foot up very well. Well, did you know you couldn't cock your foot up very well? Your foot is weak. Thank you. Oh, I didn't know that. Well, now that you mention it, yeah, I kind of noticed I've been dragging my foot and kind of tripping a little bit. Okay, well, you've got weakness, and that's due to a pinched nerve in your back. So we need to go unpinch that nerve. And that's what this surgery is for. Now, are there other surgeries that could be done? Absolutely. You can have an open back surgery, and with it you can have infection, instability as a result of the surgery where the surgeon takes off too much of the joints or bones or ligaments, and it weakens the spine to the point that it needs a fusion. Very, very common things that happen with with open surgeries like microdiscectomy, laminectomy. Okay? So one of the reasons we do the Duke laser disc repair endoscopic surgery is, number one, to have the best results possible with relief of back pain or neck pain if it's in the neck, arm and leg pain, basically. So 95% relief or resolution, that means it's gone. 95% is the average. If I take 100 patients and do this surgery, which I've done, 1,000, and we ask them afterwards, you know, whether it's a week, a month afterwards, and this effect has been shown to last for 6 years afterwards, by the way, with recent data that we've looked at. Those patients say 95% of my preoperative symptoms are gone. 95% of my preoperative pain in my back is gone. 95% of my preoperative leg pain is gone. So 95% elimination of preoperative back and leg pain or neck and arm pain is phenomenal. There is no other surgery that does that on average. So yeah, you may get a home run with a fusion. You may come in, have a herniated disc, get a fusion done with a decompression, and you have 100% relief. And Duke laser disc repair has 100% reliefs as well. As a matter of fact, about a third of our patients have 100% relief, 1/3. So that's more than open surgery. We're not talking about once in a while hitting a home run. We're talking about loading the bases and hitting a home run 95% of the time. That's phenomenal. There is no surgery in the world or surgeon in the world that has as good results for back surgery, period. Now you add on top of that the fact that at Duke Spine Institute with the Duke laser disc repair, we've never had a complication. So no infections in 13 years of doing the surgery. No infections, nobody dying, no liver lacerations, gallbladder injuries, no vascular injury, organ injury. We've had 1 or 2 cases where the patients have had some temporary weakness because the nerve was being pinched or irritated so badly, and that they've recovered. But aside from that, we've had no complications, no nerve damage, spinal fluid leaks, no infections. So there's a lot of bad things that happen with spine surgery, or can happen. And if you go and have open spine surgery somewhere, there's probably a 10 to 20% chance, maybe even higher, that you're going to end up with a really serious complication from the surgeon and the surgery, or the anesthesiologist and the surgery, okay? So why is Duke laser disc repair so special? Because it has the highest success rate of getting rid of back and leg pain or neck and arm pain of any surgery in the world. And it has the lowest complication rate, basically 0. Over 1,000 surgeries done in 13 years. So if you have a surgery with the highest success and the lowest complication rate, shouldn't that be the surgery you'd go for? I would. I'm not dumb. I mean, I'm a patient too, right? I have to go out and figure out how to get certain things fixed. And I would love to have a surgeon that has a surgery that will fix my problem 95% of the time and doesn't not have a complication. That's the surgeon I would pick. That's the facility, wherever he does his surgery, that's what I would pick. All right? Why? Because there's a lot of bad surgeons out there, and there's a lot of bad surgery being done out there on the spine. And I see it because these people come to me after they've had surgery elsewhere, and they have problems. Like the first case, for example, okay? That patient had a fusion right where she still has a problem. The surgeon never took the herniation out and unpinched the nerve. So I have to go back to an area that's already been fused and deal with the annular tear and the herniation because the patient's still having symptoms from that. How would you feel if you went and had surgery and it didn't fix your problem? Okay, now that's possible with any surgeon, but you want to go somewhere where it's the lowest likelihood that it's going to happen. And the Duke laser disc repair, in all my years of experience, is exactly that procedure, okay? Why are we talking about this? Because we do spine surgery here at Duke Spine Institute, believe it or not. We do spine surgery. We don't really do brain surgery. I'm not going to tell you that we have the best brain surgery for you, even though I'm a brain surgeon. Yes, I'm a brain surgeon. For those of you who didn't know that, I'm a neurosurgeon. Neurosurgeons do brain surgery. We are the brain surgeons, okay, period. I'm not going to tell you that I'm the best surgeon to do a brain shunt to take spinal fluid out of the brain and put it in somebody's belly, because I'm not. I'm not going to tell you I'm the best brain tumor surgeon in the world, because I'm not. I'm not going to tell you we have the best aneurysm surgeries for brain aneurysms, because I'm not. What do I do with those patients? I send them, when they come to me, I send them to the very best that I know that they can go to and get the best surgery done with the safest, lowest risk of complication, and the very highest quality surgery. So Duke Spine specializes in herniated disc, spinal stenosis, radiculopathy, or pinched nerves. That's what we specialize in. We also do some joints. We do stem cells. We do platelet-rich plasma. We've been doing it for years. We have a very good program. But essentially, if you've got back or neck pain, leg or arm pain, we do it better than anyone in the world. We do it with the very best. And that's based on our results. That's based on our patients' results, not results that I calculate, results that the patients tell us. Okay? So why are we talking about this? Because that's what I chose to talk about, because nobody had a question. Do we have any questions yet? No. All right. Well, it looks like everyone has their answers to their questions, if they even had any. We're going to close this surgery, and we're going to move on in a little bit to the third surgery, which is really the second surgery, because we canceled the first one.